Good afternoon, everyone. First of all, I would like to thank Dr. Mrna for inviting me to this very important ACT meeting to speak about COVID vaccine, the shot in the arm. Now, I would like to dedicate this presentation to all those healthcare worker, frontline worker, as well as people who have died because of COVID while waiting for the vaccine, and how much we wish that the vaccine was available earlier so that we could have saved many of them from dying of such a disease, which now is vaccine preventable. So this is the structure of the SARS-CoV-2 virus, which is the cause of the COVID-19, which has shook the entire world in the form of pandemic since 2020. And this virus has a lot of surface proteins, but of which the most important is the spike protein, because the spike protein is the one which attaches to the ACE2 receptor on the human body, essentially in the respiratory tract, but also in other organs like pancreas, heart, etc. And if you develop an anti-spike antibody, either naturally or by giving vaccines, then you prevent entry of this virus into the human cell, because it will block the attachment of the virus to the ACE2 receptor. And that is, in essence, is the way the vaccines have worked and protected, by producing a very high level of anti-spike protein antibody. And now there are various vaccines which are available in the world, and in fact, every day the count is going up. But the three which are essentially available as on today are the Oxford's, which is made locally by Serum as Covishield, which all of us have taken, and 90% of India has taken this vaccine. There's also one innovative, our own Indian vaccine made by ICMR with the NIV Pune, and commercially made by the Bharat Biotech in the form of Covaxin, which is around 10 to 15% of the population in India which have taken this vaccine. And very recently, the Russian vaccine made by the COVID Gamaleya Institute in Russia, available here as Sputnik V or Sputnik 5. Now, very soon, Zydus DNA vaccine, which will be 3-dose vaccine, will be available maybe by end of this month. And already trials are going on with Covovax, which is nothing else but Novavax, made by Serum in India. And also B is working with his own vaccine along with Baylor. And then we all know about the Pfizer and the Mrna vaccine, which are available in the Western countries, and the J&J vaccine, which was a single-dose vaccine, also available in the Western countries. Now, if you look at the Serum's vaccine, Covishield, then a phase 3 trial was done, where the endpoint was to look at the vaccine efficacy against all severity COVID disease and also against severe COVID disease. So people received 2 doses, and there were several groups, not by choice, but by serendipity, as they call, whereby a group of subjects in the original trial received the second dose late, and a group of subjects received actually only half dose for the first dose, and the error was then rectified later. So we have the low dose, standard dose, as we call the standard dose, and the efficacy differed between these two groups. As you can see here, the efficacy for those who received low dose standard dose was 90%, and that which received standard dose was surprisingly 60%. But what was important was that the efficacy against severe disease in both these groups was 100%. Now, why would a low dose lead to a better efficacy as compared to a standard dose given initially? And then it was subsequently realized, when a subset analysis was done, that the low dose standard dose recipient actually had received vaccine at 12 weeks gap, as compared to the standard dose vaccinees which had received the vaccine at 4 weeks gap. So we now know that we need to give standard dose for both the doses. But if we increase the gap between the two doses, say from 4 to 6 weeks, where the efficacy could be low as 55 to 60%, to 12 weeks, where the efficacy goes up to 81%, then overall efficacy becomes around 66%. And this essentially was the reason why in India also, though of course all the healthcare workers took the vaccine at 4 weeks interval, now this vaccine is given at 12 weeks interval. That was as far as the Astra's vaccine was concerned. But I remind you that no matter what gap you have kept between the two doses, the efficacy of the vaccine against severe disease was 100%. One problem was noticed after this vaccine was used in the European countries, where they started seeing rare but definite cases of thromboembolism, associated with this Astra's vaccine. So on 4th of April, actually, 169 cases of the central venous sinus thrombosis and another 53 cases of splanchnic venous thrombosis and some even peripheral venous thromboembolism and some arterial were reported among 34 million vaccinated population in the Europe and United Kingdom. So that gives an incidence of almost 6 per million, or you can say around 0.5 cases per lakh. Now that's rare, but it is there. And it was mainly seen in women and those who are below 60 years and within 2 weeks of the first dose of the vaccine. So that's the reason why in Western country where they have options of using mRNA vaccines, this vaccine is not used in young women, is reserved for either men or older women. In our country, as we have no choice, as 90% of the vaccine is the Astra's vaccine, which is made by Serum. We continue to give this vaccine even to young women. Now, why was that happening? Because we knew that in a rare case, the vaccine would also induce not only the anti-COVID spike antibody, but also the anti-platelet factor 4 antibody, which activates platelet, which then leads to thromboembolism. So that is the reason why you have to be very careful with the first 2 weeks. If someone has headache, sudden abdominal pain, or a limb swelling and pain, you suspect DVT. And when you suspect DVT, don't treat them with heparin or heparin-based anticoagulation. Give them the newer anticoagulation, give them IVIG, and give them methylprednisolone. And many of them can be then prevented from going into a severe crisis. The second vaccine, which is received by 10 to 15% of the Indian population, is our own Covaxin, which is our own indigenous manufactured and innovated product. It's a wholesale inactivated vaccine. Unlike the Serum's vaccine, which is a vector-borne vaccine, this is a wholesale inactivated vaccine, like many of the other childhood vaccination, like say diphtheria vaccine, pertussis vaccine, polio vaccine, etc. So this also underwent a phase 3 trial in a huge number of subjects, almost 25,000 plus, above 18 years of age, including up to 98 years. So this vaccine had a very large range of population which was covered in this phase 3 trial. Almost 10% were above 60 years. That's where the vaccine actually is very important. And 20% had some comorbidities. Again, that's where the vaccine is important because they can have a higher risk of developing severe disease and the chances of dying of the disease. And these people received 2 doses of vaccine at 4 weeks apart. Here, there was no confusion of prolonged gap between the 2 doses. It was fixed at 4 weeks. And what they found was that the efficacy against any severity COVID driven by RT-PCR was 78%, or you can say up to 80%. But again, against that severe COVID was 100%. And that is very, very reassuring. And even again, asymptomatic transmission, it was 70%. This being a wholesale killed vaccine has a more chance of even preventing an asymptomatic transmission. Now, this is important because if that is happening, then not only it prevents COVID and severe COVID in the vaccinee, but it will also block the transmission so that you can halt the outbreak of the virus happening in the community. And when this was further stratified, then you can see, as I said, against severe, any symptomatic COVID was 77.8%, and against severe COVID was 93%. You can see whether it was 18 to 59 years or above 60 years, or if they had a pre-existing medical condition, etc. The efficacy was almost very similar between 66 to 80%. So our own vaccine doing extremely well. Of course, we are still awaiting this vaccine to be given the EUA by the WHO, because then those who have taken this vaccine can actually travel internationally with a valid certification from India. The third vaccine which came was the Sputnik vaccine from Russia. Again, this is like the Serum's vaccine, adenovirus vector-borne vaccine, but uses a different adenovirus vector. In the Serum's vaccine, it is chimpanzee adenovirus, and in the Russian vaccine, Sputnik, it is the human adenovirus. So there are 2 different adenoviruses. There are adenovirus 26 and human adenovirus 5, which are used for the first and the second dose respectively. Now again, this vaccine underwent a phase 3 trial in Russia with huge number of subjects enrolled. Again, a lot of them had comorbidities, and though they were more than 60 years to actually tell us what's happening in this high-risk community. They received 2 doses, 21 days apart. The first dose was the adenovirus 26 vector vaccine, and the second was with the adenovirus 5 vector vaccine. And again, at different time period after the vaccination, the efficacy was tested, and the efficacy was found around 90 to 92%, no matter which way you look at. And again, if you stratify this as per the age group, then whether you are young or above 60, the vaccine efficacy is nearly same 90%. Whether you are male or female, again, the vaccine is similarly effective. And against moderate to severe is again 100%. So all the three vaccines have near 100% efficacy against severe disease. And I think that is what we want. You don't mind if you get a little cough, cold, fever, get all right in 2-3 days time like flu, so far as you are not hospitalized and you don't die. And all these three vaccines promise to do that, cut down the hospitalization and the mortality significantly if you are fully vaccinated, and the efficacy starts 14 days after you have taken the second dose. Only thing is, the current vaccine which is available in India has to be stored at minus 18 degree or below. Very soon, our own manufacturing site will start with a vaccine which will be 2 to 8 degree, a freeze-dried vaccine, so that you don't have to worry about minus 18 degree temperature control in the sites where you are vaccinated. I will just touch upon the other vaccine because they are likely to come in our country, or some of you may get this vaccine when you travel abroad. So the Pfizer's mRNA vaccine, which is like the talk of the town, there 2 doses given at 21 days apart. And again, a phase 3 trial on 43,000 subjects looked at the efficacy, not only in the general population, but also in elderly population and people with diabetes, obesity, and other comorbidity. And what they found was the efficacy of the vaccine was around 94 to 95%, which was similar to our vaccine, a shade little better than our vaccine. And again, severe COVID vaccine, again, it was around 90%. So irrespective of the severity, the efficacy remains at around 90%. And now they have a 6 months follow-up in these subjects, and they've seen that the vaccine efficacy sustained at same 91%, even 6 months after follow-up, and nearly 100% against severe COVID, even at 6 months after the last dose was given. And the other mRNA vaccine, again made in USA, is the Mrna vaccine, which is actually given EUA by India. And Cipla is supposed to bring this vaccine. I don't know when they'll bring, but this vaccine also underwent a phase 3 trial in USA, more than 30,000 subjects. And the end point was to look at the efficacy against severe disease and all severity COVID infection. And again, you can see here overall efficacy was 94.1%, including in above 65 years. The efficacy was sustained at 85%. And whether you had a comorbidity or you didn't have comorbidity, the efficacy was similar at 90 to 95%. So again, a very promising vaccine as far as the high efficacy is concerned. And this vaccine also has efficacy against severe COVID, which is nearly 100%. So most of the vaccine, as I said before, seem to be doing very well to prevent hospitalization and death. And a 6 months follow-up of this vaccine subjects is done, which is recently not published but available as information, which shows that the efficacy persists at around 90%, even 6 months after the last dose of the vaccine is given. It needs to be stored between minus 15 to minus 25, whereas the Pfizer vaccine needs to be stored at minus 80 degree. But recently, it has been also proven that even Pfizer vaccine can be stored at minus 20 degree, and it is valid for 1 month. So in our country, it might be a challenge to store these vaccines, but even a 2 to 8 degree Moderna vaccine can be good for 1 to 3 months. And I think if these vaccines come, then it is possible to use in our country, where you quickly bring vaccine and use it within a month after import. There are side effects of this mRNA vaccine, like how there was thromboembolism following serum vaccine. You can get lymphadenopathy, you can get allergic rash, delayed large local reaction like swelling, pain, induration, really large, like 5 centimeter, 10 centimeter large reactions. Anaphylaxis, though rare, is possible with mRNA vaccine. And what is now suddenly reported is young men, boys, getting acute myocarditis. So Israel was the first to report this rare but definite complication of mRNA vaccine in April, where there are 110 cases in 5 million vaccinees, giving the incidence of 1 in 50,000. 90% of them were young males below 30 years. And they were all within a week of the second dose. So like you are worried about young women getting problem with the Astra's vaccine, you have young men getting problem with this mRNA vaccine. And this was then followed by also other parts of the world using this vaccine, showing you that there are cases of acute myocarditis. Of course, this acute myocarditis is mild, recovers in most, come with chest pain and breathlessness, and you need to give them either anti-inflammatory or steroids, and most of them recover. The other vaccine which is available and likely to come in India is Johnson's vaccine. It is a single dose vaccine using the same human adenovirus 26 as is used by the first dose of the Sputnik vaccine. A phase 3 trial was done in eight countries with more than 43,000 subjects, and you can see the efficacy was 66%. Because this is a single dose, the efficacy is lower as compared to 2 doses of the other vaccine. But again severe disease, it was around 85%. Now, there is a problem of these mutants. You have these alpha, beta, gamma, delta. They were given as UK, South African, Brazil, and Indian variant, but now we don't call them by the A country because they're spread all over the world. What do these variants mean? They mean higher transmissibility. So they will choke up your healthcare. They would mean higher mortality, either because it's a more potent virus or because it chokes up the healthcare. People don't get timely treatment, as what happened during the second wave in India, where there was severe lack of oxygen and beds in the country. They can escape the natural antibodies, so there is a chance of reinfection. They can escape also the antibody which are used now, the monoclonal antibody which are used as treatment. And lastly, if they escape the antibody, then they can be having vaccine failure by vaccinated people getting the disease because of one of the variants. Now, let's see how these vaccines work against these variants. So the first study which shook the world was the Astra's vaccine against the South African variant. And it found that in South Africa, where a predominant strain circulating, 95% was the beta variant 1351, the efficacy was just 10%, which was not even significant. So it made the world to look into other variants and the antibody levels which are required to neutralize these variants. Fortunately, again, the UK variant, most of the vaccines work as good, including our Covaxin, where you can see whether you have the antibody against the original strain, the UK strain, or the Indian strain, they are all overlapping. So which means the vaccines is going to work as good. The Delta variant, which seems to be spreading all over the world and is the common cause of the second wave in India, where more than 60 to 80% of the cases were Delta variant. And now it has moved to the entire world, including in Israel, where there has been a breakthrough cases in vaccinated population. There were studies done, including the 3 studies using either Covaxin or Covishield, and they found that the antibodies required to neutralize this virus was around 2-fold higher requirement than against the original strain. But because the vaccines produce a very large number of antibodies, probably the vaccine is going to work even against Delta variant. Same way it was found that for mRNA vaccine also, there was more requirement of the antibody than against the original strain. But again, as the antibody levels are very high, probably you won't have a severe disease as a breakthrough. And in fact, that was the experience that a lot of healthcare workers who had been vaccinated by the time we had the second wave in India, though they got infection, very less chance of hospitalization and very less chance of mortality. So our own Covaxin has been tried against the Indian Delta variant. It is found that the antibody required are around 1.9 times more than against the original strain. But because we have a lot of antibody produced, our Delta variant is not going to be a problem for vaccinated population. Now, efficacy of the mRNA vaccine against the variant was tried in Qatar. Qatar had, when this trial was done, 50% were due to UK strain, and almost 44% were the South African or the beta strain. So alpha and beta were the predominant variant. And yet look at the efficacy was around 90% of the Pfizer's vaccine, which even otherwise was 90% against the original strain. So while it did drop against the beta variant to 75%, yet against severe disease was 100%, whether it was the original strain or the alpha strain or the beta strain. So again, the vaccines are going to work to prevent hospitalization or mortality. Lastly, what happens if you use this vaccine as mass vaccination? So Israel started mass vaccination in December 20 using Pfizer's mRNA vaccine, and you can see a very high level of coverage was there in the community. Almost 50% were completely vaccinated and 70% were full single dose vaccinated, and people above the age of 60, in fact, had even more vaccination coverage than the young population. And this is what happened. If you were fully vaccinated, like above 60 years, your cases dropped by more than 77%. And even in young, where the vaccination coverage was not as great, there was 52% drop in the cases. So it is possible to halt the transmission of the virus if you have a lot of herd immunity in the population. Now, the last part, do you need booster? A lot of talks are happening. Everyone is asking for booster. IM has asked for it. People have been asking for booster. Somehow, the health authorities and the ICMR is against giving booster, very rightly so, because we have still not covered 2 doses to enough population. So, you hear these news, corona vaccination. Will you need a COVID booster? Someone, Times of India, Mumbai hospital start receiving requests for booster dose from the health staff. In fact, it also said that the healthcare workers and politicians have been taking this booster outside the app through their own sources. And Pfizer has made a case for booster application in the USA to allow a booster dose. Why all this happening about the booster dose? So Israel was the first to study the effect of booster. As I said before, after controlling the disease in Israel with mass vaccination, they opened up. So the gyms were open, the pubs were open, the theaters were open, the schools were open, socializing was open, all functions would happen, except for very highly crowded area. Even mask was not compulsory. And then came the Delta variant and they started seeing breakthrough cases. So they are the first to study the effect of a booster in people where booster may be important because they are at risk of developing severe disease. So they took 60 years or older fully vaccinated people who had received the second dose at least 5 months before the study began and enrolled them, half of them to receive a booster of the same Pfizer mRNA vaccine and half of them serving as control. And they looked at the rate of confirmed COVID-19 cases, both severe and any severity, in boosted group versus control group. And what they found? And they found that in confirmed infection, the boosted group had 11 times less disease burden as compared to non-boosted group. And when it comes to severe illness, it was 24 less in boosted group compared to non-boosted group. So they first time saw that someone who has received a booster at least 5 to 6 months after the last dose, it works better in the form of reducing the disease burden of any COVID by 11-fold and severe COVID by 20-fold. And that's how they have now planned to give a booster to the entire population, starting from people at 60 years and above and people with comorbidity, percolate down generally to the other population. And you can see here that after 6 to 7 days of the booster, you can see the massive differences between the boosted group versus non-boosted group. So it works as fast as 1 week after you've taken the booster that your chances of getting disease goes down drastically. So to boost or not to boost, why do we need booster for COVID? Maybe people who have lost the immunity, especially immune compromised elderly population, may benefit out of booster, as was seen by the Israel experience. Whom to give? I think the priority will be people above the age of 60 and people with comorbidity. When to give? At least 6 months after the last dose as per Israel, and United States is very soon going to start giving booster 8 months after the last dose. So we could say 6 months, 8 months, 1 year after the last dose. Which vaccine? So mRNA vaccine and killed vaccine, you can use the same vaccine. Vector-borne vaccine, probably you give an alternative vaccine, what we call heterologous boost, or someone may come out with a tailor-made vaccine for the variants so as to give a better efficacy. Is it safe? The answer is yes, it is safe to give. In fact, those who had received the Chinese Sinopharm vaccine in the UAE, the Dubai and around areas, are given again a booster of either mRNA vaccine or any other vaccine if they have taken the Chinese vaccine, because it was not found to be as good. Do we have enough stock? As I understand, more vaccines are going to enter, and by September, October, there is a liberation of the number of doses available. So probably that should not be the reason why we would not give booster. And is the booster given for scientific reason or political? I think it is given for scientific reason, as proven by the Israel experience. So I think we should not look down upon a booster, though we may decide when you need booster in our country, but I'm sure someday we will need a booster. Will you need an annual booster like influenza vaccine? My gut feeling is no, because I have a feeling that this disease is going to come under control very soon. 82% of the Indian population are antibody positive, either because of natural infection or because of vaccine. So we have achieved herd immunity, and you can see the disease is on decline, at least in our country, since last few months. There is a lack of equity in vaccine access. You can see the maximum vaccinated population is in the rich countries like United States, Canada, UK, etc. Look at Africa. Only 4% of people are fully vaccinated, and another 6% have received one dose. And look at the world, 32% versus 44%. And India, 16% versus 29%. So we have a lot to desire for these rich countries to donate vaccine to this poor country, because it's in their own interest. Unless COVID is out of the world, these countries also cannot say that they are out of the bounds, because the virus can spread like wildfire. So I will end my talk by this unanswered question. What if the COVID virus mutates further and completely escapes antibody? That will be a disaster. But I'm sure the vaccine manufacturer will come out with the solution of having another tailor-made vaccine to prevent this mutant which is going out of hand. What if COVID-19 disappears by the vaccine comes? It seems that COVID-19 is declining because of vaccination, and it is still there. So we will need the vaccines for many years to come. Is there a serological corridor of protection? People keep on doing antibody level. Unfortunately, we don't know at what level you are protected. But one thing is there, that if you have antibody, probably your chances of hospitalization or death is much lesser as compared to if you have not seroconverted or if you have not taken the vaccine. Titers don't matter, because all you need is a good reaction to the vaccine. And if you have immunological reaction, then you have T cell memory, which will work for your life, like for all other vaccines. Will a booster be required? I discussed in length in the last few slides. I have a feeling we will need a booster, at least one, in the coming few months. Can you mix and match the vaccine? Not by choice, by default, you might have to do. And will poor nations receive vaccine? Yes. WHO is working very closely to secure 2 to 3 billion doses of vaccine by donation, so that the poor country can also get their share of vaccine and become disease free. When will COVID end? I don't know. I wish as early as possible, because I am also equally bored of wearing masks. But till it happens, please continue the three things: social distancing or physical distancing, wearing a mask, and sanitizing your hands or washing your hands with soap and water, because besides vaccine, that is the definite way of preventing COVID infection happening in you and your family. Well, once again, I will thank you all for your patient hearing, and I would like to congratulate ACT for including this COVID vaccine as a part of the scientific program. Thank you very much.